I'm delighted to be here today. I think what you're doing in Minnesota is absolutely phenomenal. I think this is an enormous effort. I think you guys should take great pride in your hospital-wide effort to improve outcomes for patients with severe sepsis and septic shock. And I think the approach that you're taking of getting out in front of it and approaching it proactively is the right way to go. Like I was saying, I'm in New York. Unfortunately, we didn't have a statewide effort until we have something mandated by our Department of Health, which has its own pluses and minuses to it, but I would say it's a better approach to be out there ahead of time and proactively and set the agenda rather than react to the agenda set by the state legislature with that. So this morning, I'm going to spend about 45, 50 minutes on slides, try and leave about 10 or 15 minutes at the end for questions. I hope you'll have some after this. So first off, I just want to say I have no disclosures, no financial disclosures. The Surviving Sepsis Campaign is currently funded by the Society of Critical Care Medicine, the European Society of Intensive Care Medicine, and also funded in part by a grant from the Gordon and Betty Moore Foundation for ongoing work with that. There's no direct or indirect industry funding associated with the guideline revisions or with the Surviving Sepsis Campaign. That I should add that I do have one sort of personal disclosure about intellectual conflict of interest, and that I actually really believe that sepsis performance improvement works. I think this is the right thing to do. I think this is how you're going to improve patient outcomes to do this. So I have a deep conviction that sepsis performance improvements works, and if you guys do this, patients will benefit from it. So this morning, we're just going to go over the outline of this morning. We're going to talk a little bit about the impact of sepsis, epidemiology, outcomes, cost, a little bit over the background of the Surviving Sepsis Campaign, which is now in its 12th year, some demonstration of success of the Surviving Sepsis Campaign bundles in decreasing mortality for patients, and some examples of successful implementation of the guidelines and what's associated with that, what factors help you adopt the guidelines, what factors may detract from your ability to apply the guidelines. So why are we all here talking about sepsis? So we're not in New York. It's not because of a prominent story on the New York Times with that. But we're talking about sepsis because it's very common, right? So everybody here has cared for probably lots and lots of patients with severe sepsis and septic shock. And when you look at national statistics regarding this, in about the 3-year period from 2007 to 2009, there were over 2 million patients admitted in the US with a sepsis-related illness. So this is not a rare disease, a rare syndrome. When you look at where those patients are coming from, this is, again, national data. A little over half are diagnosed with the sepsis-related illness in the emergency department. About a third are diagnosed on the inpatient units. And about 13%, or just slightly under 13%, are diagnosed while in the intensive care unit already. This really spans the whole hospital. I know it's going to, when you're thinking about implementing sepsis performance in your hospital, you're going to have to decide what area to focus on first. And most of the data so far has been on patients presenting to the emergency department. I know Dr. Davis has done a lot of work also looking at patients in the intensive care unit. And I think sort of the next frontier where this is going to go is looking to identify these patients on hospital units, med-surg floors earlier than we are currently. This is data from the National Center for Health Statistics. And let me see if I can get the pointer to work. I might just use the laser then. So what you can see here is the green line here is primary hospitalization. So this is a primary diagnosis of sepsis or septicemia. The blue line here is either a primary or secondary diagnosis of sepsis or septicemia. And this is the rate per 10,000 population here. So in 2000, the primary diagnosis rate for sepsis or septicemia was 11.6 per 10,000 population. In 2008, that had risen to 24 per 10,000 population, so more than doubled. Likewise, if you include secondary diagnoses as well, that went from 22 per 10,000 to almost 38 per 10,000. So it's increasing in frequency. And you might say, is that real? Or is that just that we're getting better at documenting this, right? So I think we are better at documenting this. I think that when a patient is admitted to the intensive care unit with pneumonia and hypotension, we're much better at now calling that septic shock than we used to be. So some of this undoubtedly is related to us documenting better and coding these patients more appropriately than we did. But it's also, some of this is that very much thought to be a real increase in the incidence of this syndrome in the fact that we have an aging population, we have folks who are living longer with chronic conditions that may predispose you to severe sepsis or septic shock. Okay, so we have a common syndrome. We have a deadly syndrome. So severe sepsis and septic shock are the leading cause of death in non-coronary intensive care units. And in many studies have a mortality rate between 20 and 50%. there's no other hospital condition that's associated with mortality rates like that. When you look at the hospital mortality from an ischemic stroke, most of that's reported in the 1% to 2% range. When you look at hospital mortality from an ST segment elevation MI, we're talking about mortality rates in the 3% to 5% range. But when we get to severe sepsis and septic shock, the vast majority of studies are in this 20% to 50% range. So we're talking about a syndrome that has an order of magnitude higher risk of death associated with it than other clinical syndromes, which we know are medical emergencies. So part of the goal of this morning, and I think your talks later in the day will also focus on this, is about reframing the way we think about severe sepsis and septic shock. What we need to do is not go, oh yeah, this patient has a touch of sepsis. Right? There is no touch of sepsis. Much like we know that we don't sit on a STEMI, right? If you see an EKG that has ST segment elevations on it, you act and you act immediately. We know that's an emergency. Somebody comes in with new neurologic deficits, we know that's an emergency, we don't wait. We need to reframe the way we think about severe sepsis and septic shock so that we recognize this consistently as an emergency, we identify these patients, and we act in a very timely fashion for them. Sepsis is also extraordinarily expensive. So the cost estimates vary, but they're estimated between $14 to $18 billion per year to the U.S. healthcare system, and that's in about 2008 dollars. The estimates vary somewhat based on sort of what assumptions you use to calculate the estimate. And the costs are growing at a faster rate than hospital costs overall. And when you break this down to estimated costs per case, it ends up to be about over $18,000 per case. This is data, again, from the National Center for Health Statistics that looks at length of stay for patients with sepsis. And you have three groups here. You have all age comers. This is the under 65 age group, and this is the 65 and over age group. Again, so the blue bar here is patients who are hospitalized with sepsis. The green bar here is hospitalized for other causes. So the length of stay in all ages was over 8 days for patients hospitalized with sepsis versus just under 5 for patients hospitalized from other causes. So nearly double the length of stay. And you can imagine the longer you stay in the hospital, obviously, the more cost to the system. That relationship is even more prominent in patients under 65. You can see that it's 9 days over 4.3. And in the 65 and over age group, it's 8 versus just under 6. So across the board, though, hospitalization with sepsis is associated with a longer length of stay than hospitalizations from other causes. So I hope we've painted the case for why we're talking about sepsis as a great syndrome for us to address system-wide performance improvement. It's common. It's increasing in frequency as the population ages. It's associated with high risk of death and long length of stay. It costs a lot of money. So I've painted all the bad stuff, right? So is there any good news in this? Yes. Okay. What we can do can dramatically impact the outcome. That's why we're all here today, right? I told you I'm a believer. I think this stuff works. I think you'll see lots of data that suggests very, very strongly that it does. I think there's a very compelling case that what we do with actually very low-tech interventions, we're not talking about a cath lab and specialized techniques. We're talking about IV access, fluids, antibiotics, reassessment, and then more advanced hemodynamic monitoring for a certain subset of patients. But what we do can dramatically impact the outcomes of these patients. So there is good news. There are interventions that are proven to reduce mortality and cost in this population. The problem is there's always a but, right? So the but is we don't do them all the time. We don't do them that reliably. So even though we're talking about relatively simple interventions, again, right, we're talking about bags of saline, fluid resuscitation. These aren't routinely done in all settings. But I hope that when you leave here today, and for those of you who have already engaged in the mentor hospitals who have already engaged in sepsis performance work, you'll know that applying the Surviving Sepsis Campaign bundles is an effective approach to do this, to get us to perform more reliably and do these interventions that are proven to reduce mortality from severe sepsis and septic shock. So this is an actual case from my hospital. Again, so Bellevue Hospital is a large urban safety net hospital. It's sort of the flagship hospital of the public hospital system in New York City. We have 800 beds with that. And this was a pretty standard case. We had an 82-year-old woman who was admitted with confusion, had a small hemorrhagic stroke. She's in the hospital. She's awaiting nursing home placement. And while she's in the hospital, she gets a fever and tachypnea. So the house officer was called. So we're a teaching hospital. She got blood cultures, but no other evaluation. You can kind of see this going in your mind, right? How many fever calls did you get as a turn and you drew blood cultures and kind of moved on with your night? So she got a fever. She got blood cultures drawn, no other evaluation. She got labs the following morning that showed that her white count had gone from 4,000 to 16,000, and she had a new bandemia with 19 bands. And she had acute kidney injury now with her creatinine had gone from 1.7 to 2.2. Nonetheless, we didn't put it all together. Then now you have a patient who has a new suspected infection and evidence of organ dysfunction, right? She's now got acute kidney injury. We didn't put that together to say this fits that clinical syndrome of severe sepsis. So she got antibiotics ordered, but they were ordered routine, not stat, and they were given about 8 hours after the onset of organ dysfunction. And she stayed on the floor. The next morning, she was now hypothermic. She was now hypotensive. They started giving her fluid boluses, but she had a history of systolic heart failure, so it was done in this kind of incremental small boluses. She got 250 cc's here, blood pressure responded a little bit, got another 250 cc's here, but was not managed aggressively with that, and she was subsequently transferred to the medical ICU where she died 3 days later. So this case, unfortunately, is not that rare. I think all of us who operate in the clinical environment have seen cases play out like this. And it's not because the clinicians had bad intentions and they wanted to not recognize sepsis in this woman. It just was hard to kind of put it all together, and we didn't have a system in place to help folks put it all together. Okay? But what we have here is a pretty comprehensive failure, right? We failed to recognize severe sepsis when it was present. We failed to try and identify it early. We failed to provide timely antibiotics. We failed to provide timely fluid resuscitation. And clearly we have a very, very negative patient outcome from that. So again, I'm not going to go in detail into any of the bundles. I'm just going to mention them briefly, and I know you're going to get a lot of talks later about the bundles. But there's a very compelling case for why early antibiotics matter. So this is data that you're maybe familiar with already from Kumar from Canada. And basically what this looks at is on the graph here you have this. The time zero on this graph is the time the patient, the first notation of hypotension for the patient. So this is already kind of late in a hospital course for a patient with severe sepsis. So this is when hypotension is noted. The black bars here are the proportion of patients that survive, and the gray bars here are the proportion of patients who received antibiotics, and on the x-axis here you have time. So for example here, this is within the first half an hour. So this is from time 0 to 0.49 hours, so within the first half an hour. If your patient got antibiotics in that first half an hour after hypotension, their likelihood of survival was over 80%. Okay. By the time, well, where was my patient? 8 hours? By the time you get to this 8-hour bar, that patient's likelihood of survival has dropped to 30%. And when you do a regression model on this, at each hour delay with giving effective antibiotics was associated with a mean drop in survival of over 7.5%. So this is pretty stunning data to me that shows that, boy, even if I'm an hour slow, my patient has a measurable drop in their likelihood of survival from that. So I think this paints the case for why we need to move fast on giving these patients antibiotics. Likewise, this is data from an emergency department. I believe this is from Boston. This looks at 2 different time zeros, but this is from when a patient presented. These are all patients who came to the emergency department with severe sepsis. When they counted triage time as time 0 and looked at the mortality of patients who got antibiotics within an hour of triage time versus more than an hour, the mortality rate was 19.5% for those who got antibiotics in that first hour versus 32% for patients who waited more than an hour for antibiotics after triage time. And I'm not an emergency department folks, but I know we have emergency department colleagues in the audience. That's a really hard bar to hit, right? Getting antibiotics into a patient started within an hour of being triaged in the emergency department. Emergency departments are overwhelmed as it is. That's a very hard bar to hit. When you looked at clinical time 0, which is clinician recognition of severe sepsis, and looking at that same, now mortality was 25% if you got antibiotics within an hour of clinician recognizing that the patient had severe sepsis, versus 38.5% for patients who waited more than an hour after a clinician recognized severe sepsis. This is actually data that's in press from the Surviving Sepsis Campaign, and it's a very busy table, but I'll walk you through it a little bit. So this looks at, in this now 28,000 patient database from the Surviving Sepsis Campaign from 250 some hospitals across the world, looked at this same relationship between mortality and when the patient got antibiotics relative to the onset of severe sepsis or septic shock. And you have two groups on the slide here. The top group is the severe sepsis group. The bottom group is the septic shock group. So these are patients hypotensive. This is just severe sepsis. And what you see here is your time here. So if you got antibiotics within the first hour, as opposed to immediately, your risk of death was 10% higher. If you got antibiotics at hour 2, as opposed to immediately, your risk of death was 21% higher. And all of these are highly statistically significant. And you can see that there's a very clear kind of dose-response relationship here between the time interval from the onset of severe sepsis to receiving antibiotics. That the longer you wait, the higher your mortality rate is. And this is different than the Kumar data that I showed you earlier, because remember, the Kumar data was after the onset of hypotension. So you can really say that that's potentially a shock population. This is all comers with severe sepsis. So this, again, sort of expands that group. That says there's not only time urgency to get antibiotics in a patient who has hypotension, there's time urgency to get antibiotics in any patient with severe sepsis. And you can see that the p-values are all highly statistically significant. One of the other main focuses that we're going to talk about over the course of the day is about early fluid resuscitation. Right, so we want to get these patients fluid resuscitated in a timely fashion. So I think most folks in the audience have sort of heard of the Manny Rivers study, early goal-directed therapy, and that's from 2001. And that, I think, sort of fundamentally changed the way that we approach fluid management in patients with severe sepsis and septic shock. And Manny Rivers gave 20 to 30 mils per kilo initial fluid bolus for all patients presenting to the emergency department with either hypotension or a lactate greater than 4. And that's directly where that bundle element comes from. I think the process trial, which was published 2 weeks ago now, has generated a lot of discussion amongst the sepsis community about where that falls into things. And I just want to emphasize, we're not going to go into the process trial today, but I wanted to emphasize that the process trial is actually very similar in the initial fluid resuscitation to the Manny Rivers study. So the requirements for entry into the process trial, which was, just to recap briefly, was a sort of a 3-arm study looking at early goal-directed therapy versus sepsis protocols versus quote-unquote usual care. So you had to get at least 1 liter initial bolus to be enrolled in the process trial. And when you look at what these patients actually received in the first 3 hours, all 3 groups across the study received 28 to 30 mils per kilo fluid boluses, as on average, prior to randomization. And they were randomized at about hour 3. When you look at, again, this is data that's in press from the Surviving Sepsis Campaign, and you look at the individual bundle elements and with that, but what you see is here, so this is patients who received that 20 to 30 mil per kilo fluid bolus. And this is actually from the original bundle, so this is 20 mils per kilo. Those patients had an odds ratio of 0.68 of death compared to patients who did not get that fluid bolus. So their risk of death was reduced by 32% if you were compliant with that element of the bundle. So I think everybody here knows a little bit about the Surviving Sepsis Campaign, but I'll just kind of recap a little bit of the history from it. This was the second revision of the guideline, or the third iteration of the guidelines total. This came out in it was actually published in January of 2013, but it's a 2012 revision. I think this is a really remarkable slide to me, that these are the current societies that supported the guideline development or participated in the guideline process. And you can see here that it's a global reach. You have the Asia Pacific Society, Emirates. This really represents global providers, and it represents physicians, nurses, critical care, emergency departments, hospitalists, you name it, pharmacists. All members of the care team have really signed on to this process in representing the Surviving Sepsis Campaign guidelines. So the campaign actually started back in 2002. With a declaration that came out of one of the joint meetings between the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. And they basically said, there's just a group of committed clinicians in a room that said, we think we can change sepsis mortality. That's how it started. Nothing fancy, nothing magic. And they said that we think we can do something about this. We think we can change sepsis mortality. And this group sat in the room and said, we are going to work together and we're going to come up with a plan to reduce mortality from severe sepsis and septic shock by 25%. They didn't exactly know how they were going to do it at that point in time, but it was just a group of smart people in a room, dedicated, who said, we can do this. The first step, so after that came the first iteration of the guidelines, which were published in 2004. Again, the second edition published in 2008, and the third edition was released in January. And actually, these comes across as linear, but phase 3 happened sort of in the process of phase 2 as well. And so phase 3 was really about performance improvement. What we're all here to do today is, it's all great to have a guideline, right? They're wonderful documents. They make great sort of paperweights on your desk. But how do you actually get clinicians to apply the guidelines at the bedside? How do you actually get a guideline to change practice? We have lots and lots of evidence that says that just publishing a guideline alone does nothing to change how we actually take care of patients. So phase 3 was a really unique partnership where focusing on education and focusing on implementation. They developed the sepsis bundle, partnered with the Institute for Healthcare Improvement. And you remember the first 2 bundles from the 2008 guidelines focused on an initial resuscitation bundle for 6 hours and a management bundle for 24 hours. And this effort was about facilitating adoption of the guidelines and being able to benchmark performance. The really overarching goals of these bundles and the implementation phase of the Surviving Sepsis Campaign was to facilitate early recognition. So we said it's not just enough to move fast once you recognize severe sepsis or septic shock. If you wait for me to sort of go, oh yeah, that patient had a fever, now she has acute kidney injury, now she's hypotensive. If you wait for me to put that all together, there's probably a time lag there compared to if you have a system in place that's gonna facilitate early identification of these patients. So we're facilitating early recognition through provider education, through screening tools. So not waiting for these patients to become apparent to us, but going out and looking for them. And about treating sepsis as an emergency, emphasizing this time-sensitive, evidence-based management. Again, reframing this so that it becomes sort of equivalent to STEMI and stroke. We want to make sure that we have this timestamp on it. We know the clock is ticking, and we know we need to move. We need to get early antibiotics in. We need to fluid resuscitate these patients. We need to assess their perfusion, and we need to reassess the adequacy of our resuscitation efforts. So as a means of accomplishing this, the Surviving Sepsis Campaign had this very multifaceted intervention. We had national, regional, and network launch meetings with local champions, introduced the bundles, developed educational tools, very similar to the toolkit that MHA developed for this project. Okay. There were regular web conferences and conference calls. This rings a bell with what you guys are doing, right? There's a website and a listserv so people could share ideas and collaborate across sites. You have a mentor hospital model here, which I think is a fantastic way to approach this. And you collected data, right, to look at how you're doing so that you can know, rather than just my sort of global sense of, I think I'm doing okay. You needed to actually look at that and measure how you were doing. So again, you'll get these later, but these are the National Quality Forum approved bundles, the 3-hour bundle to be lactate, blood cultures prior to antibiotics, get broad spectrum antibiotics started, and for patients who are hypotensive or have a lactate greater than 4, get that 30 mils per kilo fluid bolus in. And for us, the internists in the room, that was a sea change in how we fluid resuscitate patients, right? Now, no more 250 to 500 cc boluses. This is get a couple liters in that patient up front and fast. The 6-hour bundle is, again, that reassessment of patients of what's my adequacy of resuscitation after the first 3 hours, after that initial fluid bolus, how's my patient doing? Are they still hypotensive? Do they still have an elevated lactate? And then applying more advanced hemodynamic monitoring to patients that do not respond to the initial fluid resuscitation. So we've talked a little bit about the background of the campaign. We talked a little bit about how the campaign went about trying to facilitate bundle implementation. Now let's look at the results of how the campaign has actually performed. So like I said, there's about 250 sites internationally that participated in this. Most of them are from North America and Europe, although all Latin America is represented, Africa is represented, Asia is represented, but the bulk of the data comes from North America and Europe. And hospitals basically put data into the campaign database. And now this data was published in 2010, and this was related to the first 15 or 16,000 patients that were in the database. So we're talking about a huge number of patients with this. And up now, there's over 30,000 patients in the campaign database. And what you see here is there's 2 lines here. The black line is the resuscitation bundle compliance, and the dotted line is the management bundle compliance. And we'll kind of ignore the management bundle compliance because the management bundle was dropped in the 2012 iteration. So this is the initial resuscitation bundle compliance. And you can see this is the quarter of participation. So the first 3 months, second 3 months, et cetera, for a site to participate. You can see that the first 3 months that a site participated, that compliance with the resuscitation bundle was very low. No surprise there, right? Left to our own devices without systems in place to help us, we're busy clinicians. We don't have bad intentions, but it's hard to recognize these patients. It's hard to make sure that we're hitting all those metrics. So bundle compliance was about 10 or 11%. After 2 years, bundle compliance had gone up to 25%. And this is assessed as all or none. You only got credit if you hit all the elements. Okay, so there's no partial credit in this analysis. So that still doesn't sound great, right? You're like, well, we went from 10 to 25% compliance with all the bundle elements. Right? We're used to looking at core measures, right? Where if you have a fallout, it's like you get practically an RCA for looking at a fallout from a core measure, right? So this is still like, well, I've got 75% fallouts on my bundle compliance. But even with that relatively modest improvement in bundle compliance, when you assess it as all or none, there's actually a significant drop in mortality, which I think is incredibly encouraging to say that even small changes, even increasing your bundle compliance modestly, will dramatically reduce your mortality. And you can see here that mortality started, again, this is the same site quarter, and this is mortality here, so started at about 37%, and by the second year had dropped to about 27%. So that's an absolute risk reduction of mortality of about 9 to 10%, which is really stunning when you think about how much bundle compliance increased. So even doing anything is probably likely to affect mortality substantially. I also wanted to highlight some of this is that I know that this effort ends, the formal effort for the LEAP program ends in the end of 2014, but I want to very much encourage that what you're starting now should continue, okay? Because it's going to take time to see that change. You didn't see a statistically significant drop in mortality until about Q4, okay? So that doesn't mean that process changes aren't really important, but it's got to be a sustained effort. You got to keep it up, and you'll continue to see benefit. What I'm not showing you today is that when you look at actually now that there's more than 4 years of data in the Surviving Sepsis Campaign database, this is 2 years here. When you look at the data now up to 4 years, what's really remarkable is there's no plateau effect. So compliance continues to rise and mortality continues to drop. So it's not like you kind of hit the cap of what you're capable of. That if you continue the effort, you continue to get better, your compliance continues to improve, and your mortality continues to drop. And this is just same represented in a table form that mortality drops from 37% to 27% with a relative risk reduction of about 25%. What's really interesting as well is you could say, well, is that causal, or is that just that we're getting better at taking care of these patients overall? And when you break it down and look at, this is by source of admission, so you have patients from the emergency department here, and you have patients who are identified in the hospital. And this is an artificial division here of just of hospitals that were in the top half of performance, so closer to that 25% bundle compliance, versus the bottom half of performance, or closer to that 10% of bundle compliance. So when you look at patients who presented through the emergency department, if you were in the lower half of compliance with the bundle, your mortality was 27%. If you were in the better half, or the higher half of bundle compliance, your mortality was 23%. So improving compliance was associated at the hospital level with a reduction in mortality. And you see that same relationship here on the floors. So for patients in the hospitals that had lower performance in the bundle compliance, hospital mortality for patients identified at the floor was 38%. Hospitals that had higher performance on the bundles had a hospital mortality of 33% for patients identified on the floors. So your compliance is associated with your mortality here. What's also interesting here is this suggests, as we've talked about, is that a lot of these patients present to the emergency department, but a lot of them are also identified in the hospital already. And you can see that the mortality is higher when you're diagnosed with severe sepsis or septic shock in the hospital than if you present to the emergency department. So it also identifies a patient population that may be particularly vulnerable. I think at Bellevue, we've been working on the inpatient floors now for about a year and a half to try and really screen every patient on the floor. It has some unique challenges to it, but it really is a very vulnerable population. So for hospitals that are moving on, I would probably recommend starting in the emergency department. That's where most of the data comes from. But when you're ready to move on and broaden your scope, go to the inpatient units. It's a high yield place to go. Okay. And one more slide about compliance with the bundles and mortality. This is from Intermountain Healthcare System, which is a network of hospitals out in the American West, very, very well known for providing very high reliability care. So Intermountain started looking at the Surviving Sepsis Campaign bundles in 2004. This is 7 years of data from them through 2010, and you can see that this is bundle compliance with the resuscitation bundle. They started at 4.9% compliant with the whole bundle. By the end of 7 years, they got up to 73% compliant with the bundle. And what happened to their mortality? Remember, we talked about severe sepsis and septic shock having a mortality between 20 and 50%. So they started out at 21%, sort of already on the lower end of that group, which was pretty impressive. By the end of 7 years, their mortality from severe sepsis and septic shock is under 10%. It's actually under 9%. Nobody's seen data like this. It's amazing, but with very high compliance, it's associated with very low mortality. Still higher than STEMI and stroke, though. And I want to acknowledge Dr. Davis here, because we were on a phone call, probably several months ago, now a few months ago, for the LEAP 10 and with CMS. And Dr. Davis presented this data from St. Cloud Hospital. And I was so struck by it that I had to ask him if I could borrow the slides. And you may see them again later, so sorry if it's repetitious, but I was really struck by this data. So they've been doing this work since, again, 2004 here. And you can see that their mortality has dropped substantially. Right? Their mortality is reduced by more than half over that time period. And this is the part that I found so striking, is that it's not about the numbers, right? When you estimate how many lives they've saved in St. Cloud through application of the Surviving Sepsis bundles, he's saved over 418 lives. And I think that is really stunning when you think about the power of this to do that. So there's a lot of data out there. We could show data all day long, but it would get a little bit boring. So there's a lot of data out there. There's now over 40 studies that have been published using bundles, the Surviving Sepsis Campaign bundles or bundles very similar to that. They're all prospective cohort studies. Nobody's done a randomized controlled trial of the bundles per se. But all 40 of these published studies demonstrated that with increased compliance, there's an associated decrease in mortality. And this just shows you that, again, it's a global effort, because those are where the studies are published from. So I want to come back to my hospital again, try and break this back into the context of patients that we're taking care of. And this was 1 year after that original case, where we had a failure to recognize, we had a failure to deliver timely antibiotics, we had a failure to fluid resuscitate, and we had a patient die. So a year later, we had revamped fundamentally how we dealt with these patients. And so we had a 49-year-old woman who presented out one day after an endometrial biopsy with severe abdominal pain and fever. She was screened at triage in the emergency department. So there's our first difference. Now we'd implemented systematic screening for these patients. And her sepsis screen was positive. She was tachycardic, she was hypotensive, and she had suspected infection. She got a rapid lactate, which was mildly elevated at 2.5, and her white count was 24,000. She was flagged as a sepsis patient at triage, so she got expedited evaluation. We actually chose, when we decided to go forward, we actually implemented a sepsis team. So the sepsis team was activated. She also had a GYN consult and surgery consult. She got blood cultures before antibiotics. She got antibiotics in under an hour. She got 30 mils per kilo of fluid in that first hour. She was up in my ICU before 4 hours, had a lapse, which is really good for our emergency department and our ICU, since we operate at about 95% capacity. But we decided when we went forward with this that patients that with severe sepsis and septic shock who doesn't respond to the 30 mils per kilo in fluid go directly to the ICU regardless of what it is, that we will take over those patients, unburden the ED. We want them immediately. So she was in the MICU by 4 hours. She got pressors started. She got a central line placed. She met her MAP goal. She met her CVP goal. She met her SCVO2 goal. Urine output picked up. Her lactate normalized. And she went home on a hospital day 8 and was back at work on day 14. So a really different story than my first one, right? Different patient, of course, but very different story. So what do we need to do to improve? What do we need to do to have more of those positive stories and fewer of the misses? So we need to screen patients. Okay. So most of the data is for the emergency department. The vast majority of studies sort of start in the ED. There is some new focus now on moving to inpatient units. When we screen patients, we need to promptly evaluate everybody that meets sepsis criteria for organ dysfunction to identify severe sepsis. Okay. And we want to implement the bundles, obviously, which is the focus of the day today. When we talk about screening, There are some benefits and drawbacks. Just sort of a poll. Is everybody here using an electronic health record, or anybody still on paper? No. Okay. Anybody have sepsis screening in their electronic health record? Close-ish? Okay. You do? Okay. So there's been a lot of back and forth about whether you want to incorporate sepsis screening into your electronic health record, whether you want to do it on paper, and I think there are benefits and drawbacks to each way, and sort of what you decide to do will depend basically on what works for you locally. I don't think there's one way to say this is the right way to do it, this is the incorrect way to do it. So the paper form the pro is it's really easy, right? It's super easy to develop. You run a lot of them off the copy machine and off you go. It's also great because the nurses critically think as they screen the patient. That the limitations are it's a discrete process. It happens intermittently, right? It only happens when you complete the form. Paper can get lost, and there's no ability to automate the process, right? So you can't then kick out an electronic alert that a patient has a sepsis screen positive. For an EMR-based form, again, this is sort of the hybrid model between automated screening using sort of trolling your electronic health record versus having the form completed online. Again, it requires critical thinking, which I think is a great thing. You can automate alerts for positive screening. Problems are it takes time. It's hard sometimes to modify your electronic health record. Anybody that I think has tried to do that, probably you think it should be like a breeze, and then 4 months later you're still waiting for it to go live. So there is a time lag associated with that. And then there's a lot of interest, I think, in these real-time continuous screening EMRs with some of the newer vendors, the newer EMR systems that continuously screen the labs, can screen the vitals. The downside to them is you're not really applying that critical thinking part. There's no way for an EMR right now to really complete that suspected infection part well. Right? That's the clinical judgment part that the EMR doesn't have a ready fix for. So you end up, the folks who have looked at this, and I haven't seen much published on this, I've seen a couple abstracts at some of the meetings on this, that they end up with a very high false positive rate. So you end up with a ton of screenings that have a low predictive value with that, and you kind of almost get into that area of alarm fatigue for things that are continuously alerting that don't often reflect a serious clinical scenario. You need to develop a protocol. How many folks in the room already have sepsis protocols in place? God, a lot. That's great, right? So you want to look so we want to screen patients for sepsis. Once we have a positive screen for sepsis, we want a protocol for how we act on that. We're in New York. Most of our nurses are unionized, so it's hard for us to have sort of really nursing-driven protocols where it's very automated with that. So it depends on sort of what your local factors are on whether you can have a really nurse-based protocol to draw labs, give a fluid bolus, and so forth. Other protocols may activate a rapid response team or a sepsis team in response to a positive screen. Obviously, you're going to need medical staff approval. And I think this is actually a really clever idea. This is from Chicago. So what they do is when they screen is they have a very clearly defined next steps for patients with a positive screen. They alert their rapid response team, and they use the SBAR format for communicating a positive screen. And I think this really helps. Rather than that call, remember our first patient from Bellevue, who's an 82-year-old woman with fever and tachypnea, rather than a call about a fever, now that provider or that physician is getting a call about a positive sepsis screen. And using the word sepsis helps, right? Because sepsis, we're going to relabel as this is an emergency. So I'm saying this is a sepsis screen. This is not a fever call. It's a sepsis call. And I associate sepsis call with a need to act. So I think this SBAR format is really great. So the situation is you have a positive screen for sepsis or severe sepsis. You provide the background, obviously, the assessment and the recommendations. I need you to come and evaluate this patient for severe sepsis. It's recommended that I do these things. It's recommended that I give 30 mils per kilo bolus. Can I go ahead and do that? So prompting the action on the part of the clinician, or the physician in this case. So I think that's a great tool. I want to go over some other facilitators and barriers that have come up with this. There's a lot of talk about QI methodology for that. I know there's a lot of quality folks in the room as well. This is just my opinion. It probably doesn't matter what methodology you use. Everybody has a selected one. Every hospital has their method, whether you're a lean hospital or a Six Sigma hospital or a hybrid model, or you like, it probably doesn't matter as long as you use a method. Okay, use a system, form a team. And it probably makes sense to use the method that you're most comfortable with. You're gonna need a team approach to this, and I think that we'll go over team members on this, but the key is absolutely what you need here is you need interprofessional team at the table from the get-go. Okay, this cannot be a one-person effort. This can't be just a nursing endeavor. This can't be just a physician endeavor. This can't be just a quality endeavor. You need everybody at the table from the get-go. Keep the focus on the patient, obviously. This is all about improving care for patients. This is not about the egos of the team. You need to set goals and you need to use data. So your leadership team is going to vary depending on maybe where your initial focus is with that, but there are certain core components that you're going to want on your team regardless. Okay. I would get your administration there from the get-go, because you may need help motivating IT to make changes in your electronic health record. So if you get your administration there at the table from the get-go, they're probably going to have more buy-in to the process. You get physicians, nurses, pharmacy, respiratory therapy if they're who does your blood gases or draws your lactates, all of us, lab staff if you want expedited blood cultures, if it's not all going to be done by the physicians and nurses. Your team members need to be committed, okay? They need to have time to do this work. And obviously we need to play well in the sandbox, right? This team also needs to meet regularly. It's not I always use this analogy that I borrowed from, like Dr. Davis's slides. I borrowed this analogy from our palliative care nurse practitioner who talks about pain management and says, pain management's not a crock pot. You don't set it and forget it. You have to reassess. So this is the same thing about the sepsis team. It needs to meet regularly. That you can't just meet once and sort of have the process go off and running, that it requires ongoing use to do this. One thing is, how many folks have these folks at their hospital, the naysayers? I do. I got lots of them, right? We're New Yorkers. We have lots of opinions. Oh, my gosh. So how do you get over the naysayers? The literature, okay? Cite the data. Focus on the patient, okay? Concede that you're going to have some false positive screens. The screening process is not going to be perfect. And if you embrace that going on, saying, yes, but we want to over-recognize these patients. We don't want to miss these patients, right? I don't want to catch 70% of the patients with severe sepsis and septic shock in the screening process. I want to catch them all. I'd rather catch a few extra that end up not having severe sepsis and septic shock rather than having somebody slip through, okay? So don't let the false positives undermine the effort with that. One technique that we've tried, not with sepsis, but with some of our other performance improvement efforts that's been really fun, is make the naysayer, the sort of primary naysayer, part of your team. Get them at the table from the get-go. And that way, once they're bought in, then they own the process, and all of a sudden your naysayer is now an advocate. So that worked really well. For example, with our early mobilization project in the ICU. We wanted to get our patients up and moving in the ICU, and we had a bedside nurse who said, I'm not doing it, I don't want to do it, and so we made her part of the team, and now she's the biggest proponent of it. Okay. One of the other barriers is trying to do it all at once. Okay, so like I said, this is a complex multi-step process. It doesn't require new technology. Okay, it doesn't require an enormous mobilization of resources like getting a STEMI patient into the cath lab in the door to balloon time of an hour, okay? But it's still a lot of moving parts in this process. We've got to screen patients. We have a lot of steps that need to happen in a time-limited fashion. So break it down into manageable pieces. Don't break it off. Don't say, this week I'm going to fix everything. Okay, you got to break it down. You can pick an area of focus. Say, start with a gap analysis. Where are we falling down? Okay, we're not measuring lactate consistently at triage time for patients who meet surge criteria. That's our focus for this week. Let's get this moving. Okay, once you get that under control, move on. So this is your small tests of change, right? You mentioned PDSA cycles earlier. So these become your PDSA cycles. These are your small tests of change. This week we're going to focus on this. Next week we're going to focus on this, and break it down into a stepwise process. Otherwise, it just becomes overwhelming when you look at your data and go, my time to antibiotics on the floors is 600 minutes? Are you kidding me? Okay. Again, the clock is not your friend here. Okay. So we don't have an endless amount of time. Facilitating a rapid workup in a busy environment. We're all busy, right? Nobody has any, we've all got a lot of competing priorities that we need to take care of. We're not in organizations that have a lot of fat or dead weight for the most part, right? So we all have competing priorities. We need to somehow facilitate getting these patients prioritized. So we need to sort of flag these patients who have surge criteria at triage to be priority evaluated. Protocols will definitely help you get there. Protocols for management, if this, do this, okay? Empowering your nurses to send that lactate, to potentially give that fluid bolus if your policies permit you to do that, is a huge way to get over this. The clock is ticking, right? So we're talking about from time zero for the Surviving Sepsis Campaign for emergency department patients is from triage time in the emergency department. So you have 3 hours from triage to determine if that, to do a lot of things, right? You have to determine, does that patient have an infection? Find the likely source, begin therapy. So how are you going to facilitate getting that done in that 3 hour time frame? That's not a lot of time to act, right? So once you've identified that, think about what else you can bring to the table. Could you have the facilities to do this in your emergency department, or do you need to help get the other folks in the hospital to help you accomplish those goals? So for example, our emergency department at Bellevue is perennially overwhelmed. We have 110,000 visits a year. It's a literally chaos down there. So once we identify these patients as having severe sepsis or septic shock, we mobilize extra resources. So we will mobilize our sepsis team to come and take over care for that patient. We said that they're smart folks down there. They're incredibly dedicated, and they just don't have the staff or the resources to do this without bringing in resources from the rest of the hospital. You can think about doing the same for your inpatient services, particularly in places that aren't teaching hospitals and don't have house staff who are around. You may need to have a sepsis team or a stat nurse to come and respond. You may put it as part of your rapid response team to help facilitate management of these patients on your inpatient units. One of the barriers that gets brought up a lot is this question of antibiotic stewardship, right? We're talking a lot about early antibiotic therapy, and so one of your other LEAP projects, right, is about C. diff. So how do we balance those two competing priorities? We need to get antibiotics in our patients with severe sepsis immediately, but we don't want to give too many antibiotics to patients or unnecessary antibiotics to patients, because otherwise we'll see our C. diff rates skyrocket. So antibiotic stewardship is a tough one to balance, right? But the time relationship between severe sepsis and appropriate antibiotic therapy and the risk of death is very, very clear for these patients. So don't let a prolonged source delay the timely administration of antibiotics. Look for the source, decide on what you think is most likely, get the antibiotics started, and then I think what you need to balance this antibiotic stewardship is an incredibly strong institutional commitment to say that if this patient turns out to not have an infection, if this patient's infection can be treated with 2 days of antibiotics, you need to narrow those antibiotics and you need to stop them as soon as possible so that we minimize the overuse of antibiotics in these patients. So what we don't want is everybody on these incredibly broad spectrum antibiotics that get started for severe sepsis for 14 days, then you will see your C. diff rates go up. So you really need to balance those priorities. And so that's part of I think one of these ground level things when your sepsis team meets is you say, what do we need to do to change our maybe you already have this institutional culture. We did not. What do we need to do to change our institutional culture so that we stop antibiotics when they're no longer necessary and we stop them as soon as we possibly can? So those are some of the barriers. What can help us get this done? Again, the literature. Right, we have 40 studies that show that applying the sepsis bundles reduces mortality. Having really committed local champions like everybody in this room, right? You're all here because you want to improve, hopefully not just because somebody made you come, but you're all here because you want to improve care for your patients with severe sepsis and septic shock. So this group is what's going to sort of spearhead the change, okay? You also want to use systems. Make it easy for our bedside providers to do the right thing. Make the right pathway kind of the default pathway. Make it harder to do the wrong thing so that if they're going to go off-label, they have to make a conscious choice to go off-label. Okay. Feedback to providers can be very meaningful, right? So particularly, I think, I'll speak for physicians because I'm a physician. Physicians are competitive, right? Like, I want to know how I'm doing compared to Dr. Davis. So a little healthy competition between your providers saying, hey, Laura, you know what? Your time to antibiotics was 3.5 hours. I'm going to want to change that. So feedback to providers can be really very, very useful. One of the other things is when folks are successful, recognize that success, celebrate it, make a big deal out of it, okay? Put it up in the hallway, make sure, acknowledge it at a staff meeting if folks are doing a good job. So really give positive reinforcement when folks are doing a good job, okay? I think what you're doing here and the web conferences you have planned is a great idea. Collaborate with other hospitals. None of us face these facilitators or barriers alone, right? When we all said we all have naysayers, right? So sharing ideas about how to get this accomplished is a great idea. You have a wonderful pool of resources right here. Okay, so use them, share ideas amongst each other. This is just an example of what we send for feedback. So we have an email system as part of our EMR. So this probably doesn't project very well, it's probably very small. But every physician and nurse that takes care of a patient with severe sepsis or septic shock gets a sort of templated feedback email about that patient. So it says, dear attending resident nurse, head nurse, regarding your patient with severe sepsis, as part of our hospital-wide effort to reduce mortality from severe sepsis, we're tracking and providing feedback. We tried to make it non-judgmental. So here's your time to antibiotics. Here's your time to fluids. Did you measure a lactate? Did you get blood cultures before antibiotics? Yes, no, with that. So this case-level feedback goes out to every provider on every case. It's a labor-intensive to do it, but you know what? If you miss one now, people are like, hey, what happened? How did we do? It really changed the culture. Folks now know how their individual performance is with that. And so that's really been a very powerful tool for us. And we're collecting the data anyway, so sort of populating the email template doesn't take a lot of time to do it with that. And I get a lot of comments back saying, you know what, in fact, gosh, that guy was in the trauma slot, he was super sick, so the fluids were in, but we didn't get to chart it right away because we were busy doing, with the line. So you get some feedback about that too that shows you that folks are really paying attention with that. We're talking about something that's really common and really deadly and expensive, but we can actually dramatically affect the outcomes by doing simple things. We need a team, we need to start small, we need to use data, and I think the really, really main point I want you to take home is if we do this, we're going to save lives. And that's what we're all here for. So with that, I'd just like to thank you again for having me today. It's a real pleasure to be here. I'm really excited about what you guys are undertaking, and I'll open up to questions. Yeah. There's lots of different ways to do that. The bundle is basically just draw a lactate, whether it be a venous lactate or an arterial lactate or a point of care lactate. There are commercial point of care testing devices. So some of it's going to depend on what your facility can do in the lab, what's the turnaround time on that. So for example, we, at Bellevue, we just use a venous lactate. We use a venous blood gas because that gives us a quick turnaround time from that. We have not gone to the point of care lactate testing, but a lot of folks have. But it does not need to be arterial. So I think that's one of the sort of main take-home points too. Is you don't need somebody who can do an arterial blood gas to get you that lactate value.
I'm an infection preventionist, and as you presented the team, where do you see IP fitting into your role, into your team?
I think that's a great question. Wherever you're willing to participate. I think that having infection prevention at the table from the get-go is a wonderful component to this. I can tell you my team, unfortunately, we don't have enough staff in our infection prevention department to have them come all the time. But I think particularly when you're looking for a signal about potential adverse events of overuse of antibiotics, and having your infection prevention team integrally involved in the sepsis efforts and helping to monitor those events is incredibly key.
I was just wondering how you capture patients that aren't properly screened or that fall out, basically?
Yeah, that's particularly when we started the screening process, there's a learning curve to it, right? So what we do is we look for patients who end up in the intensive care unit. So I screen patients in the intensive care units for severe sepsis and septic shock. And then I go back and I look if their screen was positive. If their screen was negative, we look at why the screen was negative. And we've had done a lot of additional training about that as well. So for example, if a patient, our screening process, we're looking for SIRS criteria and we're looking for suspected infection. So if the patient had SIRS criteria and did not have suspected infection and then subsequently ended up in the intensive care unit with severe sepsis or septic shock, we would go back and say, why was the answer to suspected infection question no? Was it really not apparent at that time, or was that an error in the screening process? And so that's part of our feedback as well. Any other questions? It's so quiet, you could probably just talk.
Thanks. First of all, it was a great presentation. And I know that this wasn't the topic of your talk, but you have to take advantage of your national expertise in the Surviving Sepsis Campaign. Just wondering what the take is after the process trial. Do you see a change in the hemodynamic monitoring, such as, for example, do you think we'll still promote doing central venous oxygen saturations as early goal-directed therapy in the future?
Yeah, that's a super hot topic, obviously. So we just posted, what's today, Tuesday? Wednesday. On Monday, we posted the Surviving Sepsis Campaign response to the process trial with that. So just to recap, the process trial was looking at the current bundles reflect early goal-directed therapy as done by Manny Rivers, or close to what was done by Manny Rivers in his study from 2001. And the process trial was, again, looking at 3 groups that were randomized to early goal-directed therapy versus a different method of sepsis, protocolized sepsis resuscitation versus usual care. And the bottom line was that in this study of 1,300 patients, they did not find a significant mortality difference between these 3 groups. I think the process trial is an amazing endeavor to look at these patients. They screened 4,000 patients and enrolled 1,300. What's really staggering to me about the process trial is the control group mortality, or the usual care group mortality, is 18% in a population of septic shock. So these are all patients that got initial fluids and remained hypotensive or had a lactate greater than 4. So in a septic shock population, they're showing a mortality rate of 18% in the usual care group, which is really phenomenal. So the first inclination was, well, what does usual care look like in the process trial? Because most of us don't have mortality rates of 18% in patients with septic shock. Right? And so if we look at the sites that participate in the trial, they're by and large, there's 30-some sites. The vast majority of them are tertiary academic referral hospitals, that 75% of them had sepsis protocols in place prior to the process trial as well. And in that 3 hours before randomization, 75% of their patients got antibiotics. They all got 28 to 30 mils per kilo fluid bolus. So they got a lot of the 3-hour bundle elements up front with that. So I think it's really very impressive. There are 2 other ongoing trials, the PROMISE trial, which is the UK version of process, and the ARISE trial, which is the Australia-New Zealand version of process. And the way they designed them is actually kind of cool, because the PIs of all these studies got together and a priori planned to do a meta-analysis of all 3 trials together, so they have the same outcomes and endpoints, so that they can combine the data from these trials and create sort of a one large super trial from this. So right now, I think we're sort of digesting the results from process, trying to understand the usual care group better. There's no immediate plans to update the bundles based on this. We're going to wait for what PROMISE and ARISE show, and then incorporate that. I mean, the campaign remains totally committed to applying the evidence to patients with severe sepsis and septic shock. And so right now we're just going to wait for a promise and a rise to get published and sort of interpret all of that together to adjust the bundles if they need to be changed. Okay, thanks again for having me.